We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shiv Connect, welcoming you all for today's webinar, Gynecologic Cancer, organized by TNFOG. So it's my privilege to introduce the MOCs of today's webinar, Dr. Gayatri ma'am. Ma'am is consultant at Shamla Nursing Home, Trichy. I welcome you, ma'am.
She's not there.
She's not available.
Yes, ma'am. Our second MOC is Dr. T. Radhika Gauri, ma'am. Ma'am is specialist consultant in OBG and clinical lead ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you for the kind words, Sahiti. Good evening, madams and sirs. So let's move on to the session now. The first, our
Tamil Thai வாழ்த்து.
Tamil Thai வாழ்த்து.
Okay.
Let's start with the Tamil Thai வாழ்த்து.
நீராறும் கடலுடுத்த நிலமடந்த செழிதொழுகும் சீராறும் மதனமென திகழ்வடத கண்டமெனில் திக்கணமும் அதிசிறந்த திராவிடர்கள் திருநாடும் கத்த சிறு திரைநுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல்மறந்து வாழ்த்ததுமே வாழ்த்ததுமே
Lamp lighting to invoke the blessings of God. So, I welcome Vidya ma'am, who is the president of TNFOG 2025.
1 minute, I will tell about this Marathon CME, then you call Vidya madam.
Okay, ma'am. Sampath ma'am will give the introduction.
No,
Thank you.
just I want to inform, that's all. Good evening to all, and I welcome Dr. Parag, Dr. Durga Das, Dr. Vidya Prabhakar, and all the faculties and delegates and MOC Dr. Radhika. This TNFOG Marathon CME is, we are doing every month, the second Friday we will be doing. Since it was yesterday, Independence Day, and today is Krishna Jayanti, we postponed to Saturday. We have 3 sessions of this Marathon CME. First session is for juniors. We consider juniors as less than 40 years. 2 juniors will give it will be like 2 judges will be there, the same judge throughout the year, and the 2 speakers will be selected the best orator, and they will be given the TNFOG Orator Award at the annual conference. And the second session is the update. We have a separate theme. Suppose I brought up this month we had the theme as breast, because this is the breastfeeding week, August 1 to 10. So we had it at the breast. So the update will be given. And third will be the panel discussions with the same case. Since today is Krishna Jayanti and the most people, they don't want to go beyond 6. We have reduced the panel discussion. We have 2 talk by the Yuva and 1 update by the oncologist. And I welcome Dr. Parag and Dr. Durga Das, who has accepted within the short duration, I think, for conducting, because since I was in US, I was not able to organize it. Thank you. And Vidya madam, our TNFOG president, she will give a free hand to me. Whatever we are deciding, she will tell okay. And she will also implement, she will welcome all others. I welcome our president, Dr. Vidya Prabhakar, to give the welcome address. Yes, madam.
Thank you, ma'am.
Thank you, Sampath ma'am. Actually, this is Sampath ma'am's brainchild, this marathon CME. And she's been doing it for so many years now. Ever since she became the secretary, she has been doing this. And it has been actually very helpful because these are actually targeted or dedicated CMEs. It will be only one topic, which is nicely covered. So, and the UA also get a chance to speak in this. Sometimes they present a case, sometimes they do a seminar or whatever, they do a presentation like that. So each time UAs get a chance, and each time there is a panel, and each time there is an update, like she said. So in fact, we always wait for the panel also. Today we are missing that panel. Anyway, I welcome you, Chief Guest Dr. Parag Biniwale, sir. So can I have Dr. Parag Biniwale's CV, please? I'm not able to get CVs.
Hey, Priya.
So, Dr. Parag Biniwale is a senior consultant OB-GYN from Pune. He is a PG teacher and unit head, Kamla Nehru Hospital. He's chairman of the ICOG and president, Menopause Society Pune from 2018 to 22. President, Pune OB-GYN Society from 22 to 23. President, ISOPAP Pune chapter 24 to 26. National website editor, Foxy. Peer reviewer, Journal of OB-GYN of
Thank
India.
you, Dr. Vidya. Don't waste time reading them.
Okay, so actually, sir is he's got a lot of laurels to his credit, and so we are indeed very proud to have you, sir, today as the chief guest with us for this particular marathon CME. So I think when we met last, you had come to Salem, and he had said, "I'm actually very happy to see that you are given such a chance here. And if I had got all these chances as a UA, even I would have become much better." Anyway, sir, even without that, you have become the chairperson or chairman of ICOG and everything you have accomplished. So welcome, sir. Next, I would like to welcome First, let him Kasoga talk, then you can welcome Kasoga. First,
Okay.
Parag sir, let him. So only one point I want to tell. Parag sir, because of Dr. Parag, we are conducting the adolescent certificate course in ICOG for the past 5 years. Since he was secretary before COVID, I think. During that time, we started.
2019.
He is the person behind that. He was YTP committee chairperson. So he always has affection for adolescent.
Thank you. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to be part of the TNFOG webinar. My third time in Tamil Nadu in last 4 weeks, twice physically and now virtually. So thank you, President TNFOG, Dr. Vidya Prabhakar, Secretary of TNFOG, and a very dear friend, Dr. Sampath Kumari, and the entire team for having me here. Dr. Vidya, you correctly pointed out, when I received this program, I was really happy that, the youngsters are getting a platform at the state level. That is something which is really interesting because these are the opportunities that youngsters are looking for. And long ago, when I was chairman of the Young Talent Promotion Committee, this is what we tried to do. And now it is, everyone is more and more motivated to get the youngsters on board. In fact, I would also like to share that in ICOG, we've started something called ICOG Tarun Abhiyan. We will be having a second program soon where we will have young doctors who have recently finished their ICOG training in reproductive medicine. We'll be having a webinar with them. So giving an opportunity to the youth is extremely important, and especially when seniors like you are around, the mentoring has to be good. So the topics that you've chosen are really very, very interesting, and I'm looking forward to some great learning from these youngsters. So thank you once again, Dr. Vidya, Sampath, for having me here. My best wishes for the program.
Thank you, sir. Thank you so much for your blessings and your presence here. I would now like to welcome Dr. Durga Das Asrana, who is the President, Karnataka State Obstetrics and Gynecology Association. Can I have his CV, please? He's again a very enterprising president, and we have been meeting him at all the major conferences that you have had around here. And it's my proud privilege to welcome him here as guest of honor. He is member of IMS, member of ISOPAB. He is past president, Tumkur Society OBG, associate professor of Sri Siddhartha Medical College, Tumkur, and consultant in Kasturba Hospital, Tumkur. So we welcome you, and we would like you to say a few words about this webinar.
Good evening, TNFOG. Kasoga always wants to join hands with the TNFOG. We have always have some special affection, especially because Dr. Sampath Kumari's affection. At the outset, I thank Dr. Vidya Prabhakar, my dear Sampath Kumari, and the whole team of Sharavan Kumar and the whole team of TNFOG for inviting us. This adolescent program, Kasoga also have have a similar program. We conduct on the second Tuesday of every month, and 4 speakers are invited in the similar line, and same judgment, everything is going on, and we are giving prize money at the end of the year. So almost I told you, Kasoga and TNFOG is going hand in hand with respect to the academic activities. The today's topic about the breast. So sorry, before that, I'm really honored to share the evening with Dr. Parag Binevale, my dear friend. Really, I'm honored to be with you today evening. The topic today chosen are breast. Actually, breast is the platform of OB-GYN, because whenever there is a problem with the breast, first they come to the obstetricians. So we have to know about the breast in detail, and even at least though not the oncology cases, even the minor cases, we are supposed to treat and provide the surgical cure, at least to some extent, like breast abscess. These are all our domain. It's not a surgical domain, because we are not trained in that. The things are slowly going to surgeons. So the very good topic you have chosen, aptly chosen, and the youngsters, Dharini and Jayamina, the real youngsters, and to be judged by two great professors, Professor Shanti and Professor Kartika Prabhu. And the cancer update, I'm really eager to listen to it. Dr. Deepthi Mishra, the chairperson, to be chaired by Dr. Chandra Panduswamy. I greet the MOCs of today, Dr. Gayatri and Dr. Radhika Gauri. Before closing, once again, I thank Sampath Kumari Madam and all the TNFOG for inviting me. Thank you.
Thank you.
Thank you very much, sir, for those kind words. And I think Dr. Sampath wanted to say something. Yes, ma'am.
No, thank you. I told you. Proceed, madam. Nothing.
Okay. So actually, we are indeed fortunate to have such people today with us as guest of honor and chief guest. Parag Binevale, sir, with all his passion for adolescent education, as well as to bring up the yuva and the young talent and all that. And Dr. Durgadas, sir, again, who also shares the same kind of passion to bring up the yuva, and plus also he's very, very academic. So we are indeed very fortunate to have both of you here, sir. Thank you very much. And I hope you enjoy the sessions. Dr. Radhika, with that, I will hand over. We can start the proceeding. We have some very interesting speakers today.
Okay. Sir, we will call both of you in person for our annual conference.
Thank you, ma'am. Thank you.
Thank you.
And so we'll move on to the UR session first. The judges are Dr. Shanti. I invite Dr. Shanti, who is a professor of Department of Obs and Gynae, Savitha Medical College and Hospital in Chennai. And she's done her MBBS and MD from Madras Medical College. She's trained in ultrasound in OB-GYN, advanced infertility, advanced laparoscopy, and also provider and instructor course. She has got more than 25 publications, and her field of interest is endoscopy, high-risk pregnancies, adolescent gynecology. And she's an examiner for both UG and PG and invited faculty in conferences. And she's organized national and international conferences. And we have our other eminent examiner, Dr. Kartika Prabhu, who is a professor from SRM Medical College Hospital and Research Center, Kattankulathur, from Chennai. She is also a student of MMC, and she's done her MD from JIPMER. She's also an undergraduate, postgraduate teacher. Her special interests are high-risk pregnancy, gynae endoscopy, and midlife health. And she's received numerous awards, Dr. Asha Bakshi Award in the annual conference, AACC NCOG 2016, and papers as well. And she's also received gold medals. Welcome, madam. And I welcome Dr. Kartika Prabhu to introduce Dr. Dharini, who is our UA for today.
So I have the privilege of introducing Dr. Dharini. She is assistant professor from Katpaka Vinayaga Institute of Medical Science and Research Center. She has done FMIS from Sunrise Hospital, and she has more than 9 years of teaching experience. She'll be talking about the anatomy and the lymphatic drainage of breast. Over to you, Dr. Dharani.
Dr. Dharani?
Yes, ma'am.
Okay.
So I would like to start my talk by thanking the TNFOG President, Dr. Vidya ma'am, Dr. Sambat Kumari ma'am, and a special thanks to Dr. Umayal ma'am for giving me this opportunity. And a very good evening to all the seniors, Chief Guest Dr. Parag sir, Dr. Durgadas sir, and our judges Dr. Shanti ma'am and Dr. Karthika ma'am. So now I'll be sharing my screen. Can you see my screen, ma'am?
No,
No.
Dharani.
Not
No.
yet seen.
One second.
Have you logged in from the cell phone?
No, ma'am. I've logged in from the iPad actually.
Ma'am, can you see the share option, ma'am?
Yes, ma'am. I've done that, and yes, I think.
Okay. Now minimize this Zoom app and go to the PPT, ma'am.
Yes, ma'am. Can you see the PPT now?
Yes, ma'am. Thanks, ma'am.
Okay. So the topic for today is
tab, ma'am, so that we can have a better.
Is it okay now, ma'am?
Not yet, ma'am. This is like, can you change it to landscape mode?
No, that's all.
Not the phone, ma'am. Tab.
I've logged in from the iPad only, ma'am.
No problem.
Okay, ma'am. You can carry on. No
13
issues.
minutes for presentation and
Yes.
2 minutes for question and answer.
Okay, okay, okay. So the topic for given to me today is the breast anatomy. So breast is a modified sweat gland and it's an accessory organ of the female reproductive system. So it lies in the superficial fascia of the pectoral region. So vertically, as we can see in this picture, it extends from the second to the sixth rib, and horizontally, it extends from the lateral border of the sternum to the mid-axillary line. And it lies on the pectoral fascia. As we can see in this picture, deep down is the deep fascia or the pectoral fascia, above which we have the retromammary space. This space separates the breast from the deep or the pectoral fascia. And on the left side of the picture, we have the nipple areolar complex, the lactiferous sinus, the breast duct, and the Cooper's ligament, which we'll be discussing in the next slides. So, the importance of the retromammary space is that it is filled with lymphatics and loose areolar tissue. So, this loose areolar tissue allows the breast to move over the retromammary space, over the pectoral fascia. And importance of the lymphatics in the retromammary space is that the breast, along with the lymphatics in the retromammary space with the pectoral fascia, has to be dissected when a modified radical mastectomy is done, because we have to remove the lymphatics along with it. So the breast is basically divided into 4 quadrants: the upper inner, upper outer, the lower outer, and the lower inner quadrant. And we always describe the nipple areolar complex separately. Now, the upper lateral quadrant has a lateral extension known as the axillary tail of Spence. This axillary tail will pierce the deep pectoral fascia through an aperture called the Langer's foramen. Now, this will have a direct communication with the anterior group of the axillary lymph nodes. So, the importance of this axillary tail of Spence is that when we do a mastectomy, the breast tissue, the axillary tail of Spence, along with the anterior group of axillary lymph nodes have to be removed in continuity. So, we can see the axillary tail of Spence piercing through the pectoral fascia in this picture. Now, the breast is basically divided into 3 components: the skin with the nipple areolar complex, then comes the parenchyma, then it's the stroma. So, the nipple is basically a conical projection. It is present just below the center of the breast at the level of the 4th intercostal space. It is 10 centimeter from the midline. This nipple, as we can see in this picture, is pierced by 15 to 20 lactiferous ducts. And this contains circular and longitudinal smooth muscle fibers. This, when they contract, it makes the nipple stiff or flatten. And nipple has a few modified sweat and sebaceous glands. Now, areola is the pigmented skin that we have surrounding the nipple. This areola is rich in modified sebaceous glands, which will become enlarged during pregnancy and lactation. So, these enlarged modified sebaceous glands are what we call as Montgomery tubercles.
And these glands give oily secretions which will lubricate the nipple and areola. So this oily secretion will prevent the nipple and areola from cracking during the lactation time. Now, areola, apart from the sebaceous glands, it also contains some sweat glands and accessory mammary glands. Now, the one specialty about the areola and nipple is that it is devoid of air and there is no fat subjacent to the nipple and areola. And just below the areola, we can see that we have the lactiferous sinuses, the blue ones, where the milk is stored. Now, this is just a picture showing the Langer's lines over the breast. This is to show the importance of the incision that is made in the breast. So, the concept is in the upper quadrant, if the incision is going to be away from the nipple areolar complex, then it should be along the Langer's line. Whereas in the lower quadrants, the incision should be radial to prevent the nipple areolar complex from displacing downwards. So, the commonly used incisions are circumammary incision, which is also known as the Webster's incision, and we have the submammary incision called the Galliard-Thomas incision. Now, we have seen about the skin with the nipple and areola. Next comes the parenchyma. Parenchyma is basically the glandular part of the breast. So, it's a compound tubulo-alveolar gland which is secreting milk. As you can see in this picture, this gland consists of 15 to 20 lobes. Now, each lobe is a cluster of alveoli and which will be drained by a lactiferous duct. These ducts will converge towards the nipple and it will open on it. So these ducts will have a dilatation near the end or its termination, which is called as the lactiferous sinus. As you've seen already, these sinuses are supposed to be acting as the reservoir for the storage of milk. So these alveolar epithelium is lined by cuboidal and resting phase, and it is columnar during lactation. And the smaller ducts will be lined by columnar epithelium, whereas the larger ducts will be lined by 2 or more layers of cells. And the terminal part of the lactiferous duct will be lined by stratified squamous keratinized epithelium. Now, surrounding the alveoli and the lactiferous ducts, we have few myoepitheliocytes. These myoepitheliocytes, when they contract, they facilitate the passage of milk from the alveoli into the duct and into the lactiferous sinus, thereby to the nipple. Next comes the stroma. So we have seen the skin, nipple areola, parenchyma. Now comes the stroma. So we have seen that the parenchyma is the glandular part of the breast. So now stroma is nothing but the supporting framework of the gland. So this supporting framework is partly fibrous and partly fatty. And there will be fibrous band that provide structural support. And these fibrous band, as we can see in this picture, will be inserted perpendicularly into the dermis. And these bands will be called as the Cooper's ligament. That is the suspensory ligaments of the Cooper. Since they support the breast and they are inserted perpendicularly into the dermis, whenever there is involvement of the Cooper's ligament, it will be seen as skin retraction. Now, coming to the blood supply of the breast, we should know that there are 3 main blood supply for the breast. Now, as we can see in this picture, the medial half of the breast is supplied by the internal thoracic artery, which is also known as the internal mammary artery, which is a branch of the subclavian artery. Now, the upper half of the breast will be supplied by branches from the axillary artery. So, we have 3 main branches. There is the lateral thoracic, the superior thoracic, and the thoracoacromion branch. And the lower outer quadrant is also supplied by posterior intercostal artery through its lateral branches. So, this is the blood supply of the breast. So, this is just to show that the internal thoracic artery is a branch from the first part of subclavian artery. So, this picture shows us the origin of the internal thoracic artery from the subclavian artery. So, next is the axillary artery, which has 3 parts. And the first part gives rise to the superior thoracic artery. And the second part gives rise to the lateral thoracic and the thoracoacromion artery. So, these 3 arteries are the major blood supply for the upper half of the breast. So, this picture shows us the 3 main branches of the axillary artery: superior thoracic, thoracoacromial, and lateral thoracic. So, now coming to the lymphatic drainage, which is the important part of the breast anatomy. So, 75% of the lymph from the breast is draining into the axillary nodes. and 20% is draining into the internal mammary nodes, and 5% is draining into the posterior intercostal nodes. And we should know that there is a specialized lymphatic channels under the nipple areola complex, which is called the lymphatic plexus of Zappi. As we can see in this picture, the medial half of the breast is being drained into the internal mammary nodes. The lateral half of the breast drains into the axillary nodes. Some of the lymphatics from the lateral lower outer quadrant is draining into the posterior intercostal nodes. And a special mention should be made to the lymphatics from the lower inner quadrant, where we see in this picture, which drains into the abdominal nodes. So how do they drain into the abdominal nodes is that lymphatics from the lower inner quadrant connect to the subdiaphragmatic and the subperitoneal lymph plexus, thereby draining into the abdominal lymph nodes. This is important because the metastasis from the breast can enter into the peritoneum, can form deposits into the ovary, forming Krukenberg's tumor through this subdiaphragmatic and subperitoneal lymph plexus. So next is the anti-axillary group of lymph nodes will be divided into 5 different groups. That is the anterior or the pectoral group, posterior or scapular group, lateral group, central group, and apical group. So we see in this picture that the anterior or pectoral group lie along the lateral thoracic vessels and the pectoralis muscle. The posterior or the scapular group lie along the subscapular vessels. Lateral group lie along the upper part of the humerus. Central group lie in the fat of the upper axilla. The apical group is also known as the infraclavicular group, and it lies deep to the clavipectoral fascia. So these are the 5 group of axillary lymph nodes. Why is this important is the lymphatics from the breast will first drain into the anterior and the posterior group of nodes. And from there, it drains into the central and the lateral group. From there, it goes to the apical group. Finally, from the apical group, it will be drained into the supraclavicular nodes. But sometimes what happens is, lymphatics from the deep surface of breast, as we can see in this picture, pierce directly through the pectoralis muscle and the clavipectoral fascia, and they reach the apical nodes, sometimes the internal mammary nodes. So next is the, as I said already, lymphatics from the lower and the inner quadrant of the breast will communicate with the subdiaphragmatic and the subperitoneal lymph plexus by crossing the costal margin and piercing through the anterior abdominal wall.
Dharani,
Yes,
the
ma'am.
time is up 12 minutes.
Yes, ma'am. 1 more minute. So what we should know is we have 3 level of nodes, lymph nodes. So the level 1 nodes are located lateral to the pectoralis minor muscles. Level 2 nodes are located posterior to the pectoralis minor muscle. Level 3 are located medial to the pectoralis minor. Okay, so one more important thing is we have few lymph nodes in the space between the pectoralis major and minor muscle. These are called the interpectoral nodes or the Rotter's nodes. Why is this important is these interpectoral nodes or Rotter's nodes sometimes bypass the lymphatic drainage through the level 1 and 2 and directly drain into the level 3 nodes. So we should keep Rotter's node and the lymphatics that drain into the diaphragmatics and subperitoneal lymph plexus in mind when we are planning a surgical management for a patient. So I conclude my talk with a few take-home message. So we should know breast is a modified spread gland with a nipple areola complex and 4 quadrants, which is important in describing a lesion. And we should know that it is made up of skin nipple areola complex and parenchyma, which is the glandular part, stroma, which is the supporting framework. Very important thing is the lymphatic drainage, which is primarily the axillary nodes, which is in turn divided into 5 groups. And then the internal mammary and the posterior intercostal nodes. We should always keep in mind the lymphatic drainage, how the anterior posterior drains into the central and lateral, then drains into the apical, then finally into the supraclavicular node. But we should also not forget about the subperitoneal plexus and the Rotter's node, which can sometimes bypass the regular lymphatic drainage. So thank you for the opportunity, and I finish my talk here. Thank you.
Good presentation, Dr. Dharani. We have talked in depth about the anatomy, as well as you have told about all the practical importance of each part of it, the lymphatic drainage, blood supply, then incisions for breast abscess, everything. Okay, so you have covered most of it. So breast cancer is common in which quadrant?
The upper outer quadrant is most common for breast cancer.
The reason?
The upper outer quadrant has the more parenchymal part. So that is more prone for the breast malignancy.
Yes, so it has more glandular component, so it is at more risk of developing malignancy. So you told about this level 1, level 2, level 3. So what is the practical importance of that?
So when we are planning a modified radical mastectomy for a patient with a breast cancer, we have to make sure that we are removing the level 1 and level 2 nodes, ma'am. So we should know the extent of lymphatic drainage in so we have the pectoralis minor muscle for dividing the level 1, 2, and 3 nodes, which will be helpful in this identification of the nodes intraoperatively.
Okay. So is there any role for sentinel lymph node biopsy in CA breast?
Yes, ma'am. We can use ICG for sentinel node mapping to pick up the sentinel node from the usually the anterior axillary group of node.
A good presentation, Dharni.
Thank you, ma'am.
Shanti ma'am, have you got any questions?
Yeah, it was, everything was covered and Dr. Karthika has asked all the questions.
Okay. So shall we move on to the next session?
Yes.
Sorry. Next speaker, Dr. Jayamina.
Yes,
Ma'am, please introduce. Dr. Shanti ma'am, can you please introduce Dr. Jayamina?
Yes. So the next speaker for today is Dr. Jayamina, who is going to talk about the benign lesions of the breast. She has completed her UG at Meenakshi Medical College and PG at the ESI PGIMS Kolkata, and she is working as assistant professor in Sri Muthukumaran Medical College, and she has co-authored in FOGZ Focus on high-risk pregnancy and adolescence. So over to Dr. Jayamina.
Thank you, ma'am. I'll just share my screen, ma'am.
Please keep up the time.
Yes, ma'am. So good morning to, okay, ma'am, I can start my presentation, ma'am?
Yes, please. Please go ahead.
So good evening to one and all present here. I will be presenting about the benign lesions of the breast. So coming to the definition of the benign disorders of the breast, it is a heterogeneous group of condition which consists of any masses in the breast, cyst, or any breast pain, inflammatory diseases of the breast, and abnormalities detected by any imaging like ultrasound and mammography, and skin disorders of the breast. So to classify this benign disorders of the breast, we have used a system called aberration of normal development and involution, which classifies the benign breast disease based on the deviation from normal breast development. And these breast conditions are not actually distinct diseases, but they are actually aberrations which from the normal development. So according to the Andy classification, we have 3 groups based on the based on the years. They are in the early reproductive, the late reproductive, and the involuting age. The early reproductive age is from 15 to 25 years. We have the disorders like fibroadenoma, which is a deviation from the lobular development, adolescent hypertrophy, which is deviation from the stromal development, and nipple inversion, which is due to the abnormalities in the ductal development. So coming to the late reproductive years, we have due to the cyclical changes of the menstruation, due to the hormonal conditions, we have the cyclical mastalgia or nodularity, and due to the epithelial hyperplasia of pregnancy, we have a bloody nipple discharge. And in the involuting years, it is classified based upon the lobular and the ductal involvement. In the lobular involvement, we have the disorders like the macrocyst and the sclerosing lesion. In the ductal involvement, we have dilatation of the duct, which can present as ductal ectasia, and sclerosis of the duct, which can present as nipple retraction. So due to the epithelial turnover, we can have epithelial hyperplasia with atypia and also without atypia. So for the ease of this benign breast disorder classification, I have chosen the ACOG because this classifies the benign breast disorders into non-proliferative, proliferative without atypia, and atypical hyperplasia. So first we'll be discussing about the proliferative, which includes the simple cyst. The simple breast cyst is the most common type. It is due to the kinking or narrowing of the ductules, which leads to the accumulation of secretions. It occurs most commonly between 35 to 50 years of age. It can also be and microcyst, which is seen incidentally in mammogram, or macrocyst, which is seen on clinical palpation. When the cyst, other type of cyst is the complex cyst, which has a solid component in the cyst wall and which necessitates a core biopsy, and also complicated cyst, which is defined as a cyst containing intracystic floating debris, which moves with the cyst, and there is no vascularity noted within the cyst. The management of the complicated cyst includes observation, which can be discussed with the patient, or if she needs some treatment, we can provide her aspiration. So the other non-proliferative lesions includes the mild hyperplasia, which is nothing but the focal thickening of the ductal epithelium, and simple papillary apocrine change, which is a focal thickening of the epithelium lining the apocrine cyst. These are all non-proliferative lesions and are not associated with increased risk of breast cancer. So next, coming to the second group, which is the proliferation without atypia, we have the fibroadenomas, which is the most common benign breast disorder encountered in the young adolescent women and young girls. Most commonly, it's seen between 15 and 25 years of age. It is typically nothing but a very small, it is also called as a breast mouse, very small cystic, very small lesion, which was solid lesion, 1 to 2 centimeter in size. So since it is a solid lesion, we need ultrasound to distinguish it between other lesions. So next, if the fibroadenoma is more than 5 centimeters, it's called giant fibroadenoma. It is rapidly growing, so it might need excision. So indication for surgical excision of the fibroadenomas are age over 30 years of age. There is any suspicious on imaging for cancer if it is more than 5 centimeter and if the patient has a family history of cancer. So next lesion in the proliferative without atypia is intraductal papilloma, which is nothing but the hyperplasia of the ductal epithelium. It can be solitary and it can be associated with nipple discharge. Next is a sclerosing adenosis, which is nothing but the increasing number of size of the glandular component within the lobular units. These two lesions are associated with a small risk of developing breast cancer. So next, coming to the Phyllodes tumor, which is nothing but a fibroepithelial tumor. The median age of presentation is 40 years. It presents as a single large palpable mass. But if it is small, it is similar to fibroadenoma. So in order to differentiate between both, we need tissue diagnosis to make it confirmatory. So Phyllodes tumors can be divided into the benign, borderline, and malignant based upon the mitotic index in the high power field. It is benign if it's less than 4 per 10 high power feet, borderline when it is between 4 to 9, and malignant if it's more than 10. So next, coming to the last part, which is called as a lobular carcinoma in situ. It is nothing but it is not a precancerous lesion like the ductal carcinoma in situ, but it is an incidental finding which you see in the biopsy, which is taken for other lesion. But this is associated with an increased risk of developing cancer. So close monitoring and follow-up is needed. So we have done with the tumors. Now we are coming to nipple discharge. Nipple discharge, it can occur commonly during pregnancy and also in lactating period. But if it is seen as a single serous serosanguinous spontaneous discharge, it has to be evaluated. So most commonly, a black or a green or muddy color discharge is associated with ductal ectasia. A clear serosanguinous discharge is associated with ductal papilloma. Bilateral nipple discharge up to 1 year postpartum is normal. So galactoria is nothing but a milky discharge seen from the nipple, which occurs outside pregnancy and postpartum. It can be associated with endocrine disorders like hypothyroidism and hyperprolactinemia, and also due to some medications which inhibits the dopamine secretion. So next, coming to mastalgia. Mastalgia is one of the common symptoms that the patient come to the clinic. It can be cyclical, non-cyclical, or extramammary. Cyclical, as we all know, is due to the hormonal changes. Non-cyclical, it is related to other etiology. It doesn't have to do with menstrual cycle. And extramammary, when the cause is not the breast, but something else. So cyclical mastalgia, usually we have the pain which starts around day 14 of the menstrual cycle, and it increases in severity, and it is relieved with the onset of menses. Usually both the breast is involved, and it is due to the cyclical hormonal changes which affects the breast, the estrogen and the progesterone, which has effects on the breast. So treatment consists of supportive reassurance and supportive therapy, which includes topical non-steroidal cream, and medications can be considered if the pain score is more than 3. You can give medications like tamoxifen or ormeloxicin. So next, coming to non-cyclical mastalgia, which is not related to the menstrual cycle. It is due to some pathology in the breast like the duct ectasia or periductal mastitis. So extramammary cause of breast pain. The most frequently or the uncommonly encountered symptoms can be due to the costochondral pain, which is a syndrome called as a Teeth syndrome, which is nothing but there is no abnormality, radiological abnormality, but there is a pain in the costochondral junction. For this case also, we need to give NSAIDs. So next, coming to inflammatory breast disorder. In this, we have infective and non-infective cause. Mastitis is the most common infective cause. So in this non-puerperal breast infection, it includes periductal mastitis and tubercular mastitis. So breast abscess, which is seen most commonly during in the lactating breast, it is due to Staphylococcus aureus. The source of the Staph aureus is the oropharynx of the child, which enters through the crack nipple in the breast. Supportive therapy can be given, which includes heart fomentation, and ultrasound can be used as a first line of diagnosis. In case of it developing into an abscess, we need to give an antibiotics, preferably co-amoxiclav. If not, cloxacillin can be given. If it is not settling with antibiotics, you need to proceed to USG guided aspiration of the breast and IND if required. So next, coming to mammary duct ectasia is nothing but it is a incidental diagnosis on the mammography done for other lesion. It is a dilatation of the lactiferous duct. So skin changes in the breast can be due to an underlying malignancy of the breast, or it can be due to any dermatological conditions like psoriasis, eczema, or contact dermatitis. In case of skin conditions, what treatment we apply to the skin applies here also. But if in case of underlying malignancy, we need to be very watchful for that, and it has to be suspected when you see pudgy orange skin changes, warmth, and erythema are present in the skin. So actually, Paget's disease is nothing but it is a skin manifestation in the breast due to the underlying malignancy in the breast. So it can be seen as ulceration, it can be seen as scaling, or it can be seen as crusting. Frequently, which cancer is most commonly associated with Paget's disease is ductal carcinoma in situ. So now next, coming to the evaluation. Evaluation, we have a triple assessment. We need to a clinical examination, which includes history and examination, imaging, which includes ultrasound and or mammography, or both together, and if required, a tissue diagnosis. So how do we come to this conclusion? It's based on a thorough clinical examination. You need to examine the breast thoroughly, inspection in the sitting position, and palpation by making the patient lie down. The tips of the fingers are used because it is more sensitive to picking up any lump or masses. It is palpated in a clockwise manner and in the anti-clockwise manner. And if any lump or mass is found, it is graded depending upon the position in the breast in a clockwise manner, depending upon the right or left or upper or lower quadrant, and whichever position it is. So imaging, we can use an ultrasound or mammography. If the woman is more than 40 years of age, we use mammography because the glandular tissues are less. If the woman is less than 40 years of age, ultrasound is used because the glandular component are more. So this is an ultrasound picture showing an image of a fibroadenoma. And in the right side, we have an ultrasound picture showing a malignancy. So in a mammogram, we have three types of mammogram: the screening mammogram, the diagnostic mammogram, and the newer tomosynthesis mammogram. Screening mammogram is actually what we do for every patient who doesn't have any lesion. If the patient has any mass, we do the diagnostic mammogram, which takes a look at very specific areas of the breast. And tomosynthesis is nothing but a 3D mammogram, which is a digital reconstructed images. It is an upcoming technology. So after doing the mammogram, the reporting is given by the radiologist in the BIRATS form, which is nothing but breast imaging reporting and data system. It is a standardized tool which is followed universally, and it helps to objectively grade the breast lesions. A radiologist will categorize the lesion using the BIRATS from 0 to 6 and the breast density from A to D. So what are these BIRATS? Is nothing but we have 6 components together. The 6 categories together. So category 0 is nothing but we cannot grade it properly. Category 1, in which there is no risk of cancer, and category 2, which is there is a benign lesion. In category 1 and 2, you don't have to do anything, just a routine mammography following according to the guidelines is enough. Whereas in category 0, you need further imaging like MRI or any other imaging if necessary. And in category 3, it is probably benign. So you need to have a close follow-up. There is 0 to 2% likelihood of cancer. You need to have a close follow-up of 6, 12, and 24 months. And in category 4, where there's a suspicious of malignancy, there is 2 to 95% risk of malignancy. So definitely we need to do a tissue diagnosis. And in category 5, which is highly suggestive of malignancy, there's more than 95% risk of malignancy. So tissue diagnosis is indicated. And category 6, which is a proven malignancy, so you need to do surgical excision whenever possible. So this BIRAT system is universally followed by all radiologists in reporting any lesion in the breast by ultrasound, mammogram, or MRI. So based on this, we can decide the treatment approach, what has to be given to the patient. So a word has to be told here that even though if the BIRAT staging is low, but the patient's clinical condition or the clinical examination proves to be a malignant or your suspect malignancy, tissue diagnosis has to be done. And because the tissue diagnosis is confirmatory. So this is a picture which shows a normal mammogram on your left side and BIRAT's 5 mammogram on your right side. So this is a classification of BIRATs according to the breast density, where A is all the breast tissue is composed of entirely of fat, B is mostly fatty tissue with scattered dense tissue, and C is mixed fatty and dense, which is a heterogeneous combination, and D is mostly glandular tissue, which is extremely dense tissue. So what are the tissue diagnoses available? We have the fine needle aspiration, we have the core biopsy, and we have the excisional biopsy. Fine needle aspiration is nothing but a small bore needle is introduced and you aspirate a specimen for cytological examination. But this is not confirmatory. We have to follow it by tissue biopsy or further investigation if needed. Core needle biopsy is also a minimally invasive technique which uses 12 to 16 gauge cutting
Another
needle.
2 minutes, doctor.
Yes, ma'am. Yes, ma'am. Which uses a 12 to 16 gauge cutting needle. It is guided by imaging or palpation. And excisional biopsy is reserved for those lesions where the tissue biopsy is not possible by FNAC or core needle biopsy. So this is a picture which shows the core needle biopsy. And also this is on the right-hand side is a picture which showing USG guided FNAC. But clinical suspicion, the clinical evaluation plays a role here. Even if BIRAT's scoring is very less and you suspect malignancy, you can go for tissue biopsy or FNAC if required. So the summary, I would like to emphasize that any palpable breast mass or suspicious lesion after history and examination should be followed by an imaging, which can either be a mammogram or ultrasound. And if further you need MRI can be given. And based on the BIRAT score given by the radiologist, we can proceed if you see it appropriate, or if we suspect it can be another malignant or benign lesion, we can proceed with tissue diagnosis. So just a few words on screening for breast cancer. The NCCN guidelines divides the screening for breast cancer into average risk and high risk. Average risk is a person with no genetic or family history of breast cancer. So you can do an annual screening by mammogram from 40 years of age. It can be done as long as needed. There's no upper limit for stopping the screening. So in high risk cases where there is a family history or they have a history of previous breast radiation at 10 to 30 years of age or any other lesions which are which is HPE proven, you need to start doing screening from 30 years of age by mammogram, but not less than 40 years of age. So in conclusion, I would like to conclude that early detection and evaluation for breast masses plays an important role in preventing breast cancer. Though benign lesions doesn't progress to malignancy, it can cause significant anxiety to the patient. So proper treatment is very essential. And also awareness regarding breast self-examination plays a major role in early detection of breast lesion. It has to be emphasized to every patient on clinical visit that breast examination has a high success rate of picking up lesions very early. So this I would like to thank the organization for giving me this opportunity to present. Thank you.
Good presentation.
Thank you,
Good
ma'am.
presentation, Dr. Jayamina.
Thank you, ma'am.
You told about nipple discharge. How will we be able to differentiate physiological nipple discharge from pathological nipple discharge?
Ma'am, physiological nipple discharge is not serous or it is not blood stain, ma'am, and it is physiological is always a bilateral breast. Pathological is from the unilateral breast, and it is always associated with some lesions inside, some breast mass or something, and it can be green color or it can be dark colored, ma'am. Physiological, it is always white, clear fluid, ma'am.
Suppose patient gives history of white discharge. What medical history you want to elicit?
Ma'am, serum prolactin levels, if it's checked prior, or if she is taking any medications which might increase the serum prolactin level, or if she's a thyroid patient who's not on any medication or has never done a thyroid test in her life. Ma'am, white discharge, probably pregnancy also has to be ruled out, ma'am.
Okay, so when a young patient around less than 40 years,
Yes,
you are
ma'am.
planning to do a mammogram. Which mammogram you would prefer to use, digital or sonomammogram?
Ma'am, based on this, it's only for screening, not for any lesion, ma'am.
You're
Ma'am,
just doing a screening.
We'll proceed with a normal mammogram, ma'am. If it's not for any breast lesion, a normal screening mammogram would suffice, ma'am. If it is a breast lesion, then we need a diagnostic mammogram, which includes the higher range of digital mammogram.
Actually, sonomammogram you have to do in a young patient because they have dense breast tissue.
Okay,
So
ma'am.
more than 40 years, you have to go for a digital mammogram. So in a
Okay,
young
ma'am.
person, sonomammogram, because dense tissue, breast tissue will be dense, so it is preferable to go for sonomammogram.
Ma'am, actually, I didn't hear the word sono, ma'am. That's why I thought there's a different type of mammogram. Okay, ma'am.
Okay.
So what about in pregnancy? How do you evaluate lesions in pregnancy? Investigation of choice.
Ma'am, investigation would be an ultrasound in pregnancy, ma'am, because they are less than 40 years of age and the breast tissue is also glandular. So an ultrasound has a better visualization in terms of picking up the lesions, ma'am.
Mainly because it is glandular. Okay. So anything about specific about the pregnancy and benign lesions, swelling?
Ma'am, pregnancy per se is not associated with any increase in lesions in the breast, ma'am. But if a pre-existing swelling or a mass is there and during pregnancy, it has to be evaluated because breast cancer being the most prevalent cancer among women. For that, we can proceed with imaging, and if needed, an FNAC can be done to rule out malignancy, ma'am.
Very good. So something about galactosile?
Ma'am, galactosile is nothing but a collection of milk in the cystic areas of the breast, ma'am. If it causes significant distress to the patient, you can do an aspiration or USG guided aspiration of the cyst, ma'am.
Okay. What is the common organism in breast abscess?
Staphylococcus aureus is the most common organism causing lactating breast abscess, ma'am. It can be treated by giving antibiotics and proper milk ejection and hot or cold fermentation, whichever patient is comfortable. And antibiotics can be co-amoxiclav because it has a high rate of success rate, ma'am.
Okay. So when you admit her, is it an OP procedure or like?
If the pain is tolerable for the patient, if it's not developing into abscess, we can treat it as an OPD procedure. But if it's developed into an abscess, we need to admit her and properly give IV and antibiotics can also be given because we don't want to do an IND on the patient now. And we should advise her not to feed from the breast directly. Expressed milk can be given. If the left breast is involved, you can express milk and give from the left breast, but she can give from the right breast now. And proper nipple care and other precautions has to be taken.
Okay. Okay, very nicely. We have covered almost all the topics.
Dr. Shanti, this is Dr. Ramni Devi. I would like to add a few points because there is no, it is not a must that you must not feed from the breast where you have had an abscess because now the current concept is we are doing only aspiration. So in aspirated breast also we can go ahead. And another thing is there is what will you do when you find multiple fibroadenomas in the breast? That is also a very common condition among the young girls. Will you go for surgery or will you go for medical management? If so, what will be the medical management?
Ramani madam, question is only by judges, not by the audience.
I wanted to add up.
You have to give the answer. Ramani madam, you give the answer.
Yeah, the answer is we can treat with selective estrogen receptor modulators, sperms. Civista is orniloxifene is an excellent drug for reducing the size of fibroadenomas. You did not put multiple incisions, so once when you have confirmed it, it is not a malignant lesion. Treat them with orniloxifene. It can be used both for fibroadenomas as well as fibrocystic disease. It gives an excellent pain relief as well as reduction in the size.
Yes, ma'am.
Thank you, madam.
But anyway, it was a very good presentation. Thank you.
Thank you, ma'am.
Thank you, Ramani madam. And Kartika and Shanti, really, I should thank them. They want to celebrate Krishna Jayanti. I told nothing doing 30 minutes, you should be here. Thank you, both of you.
Thank you.
Ramani madam.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Ramani, ma'am. And thank you so much, Dr. Shanti, madam, and Dr. Kartika Prabhu. Thank you so much. And nice presentation, Dr. Dharni. Now we are moving on to the next session. Topic is cancer updated. Chairperson is Dr. M. Chandra Pundasamy, ma'am. The speaker is Dr. Deepthi Mishra, ma'am. So I invite Dr. Chandra, ma'am, who has done her MBBS, DGO, FICOG, and DRM. And she's done her UG and PG in Government Stanley Medical College, Chennai. She's a gold medalist and started the first laparoscopic and IVF center of her district. And she's delivered the first IVF baby and ICSI baby of her district. And she's affiliated to FOXY since 1982. Life member of IMA, ISR, Images, IAGE, PCOS Society. Founder, President of Namakkal Women Doctors Association. And founder, President of Namakkal OG Society. EC member of TNFOG, registered ISR faculty in many national conferences. And she's received NEMA Best Doctor Award, Best Woman Achiever Award, Best Fertility Consultant Award, ISAR Dronacharya Award 2023. With all these credentials, we welcome her. Ma'am, I invite Dr. Deepthi Mishra, ma'am.
Ma'am, can you hear me?
Yes, ma'am.
Yeah, thank you. My video is not working. Sorry, I just wanted to confirm.
Okay, we can hear you. So I welcome Dr. Deepthi Mishra, ma'am, who has done her MBBS from Government Medical College, Berhampur, Odisha.
Madam இல்லையா?
வரேன்னாங்க மேம் இன்னும் காணும்னு நினைக்கிறேன்.
Introduce பண்ண. Okay, no problem.
Okay. She's done her general surgery, MS, KGMU, Lucknow, UP. And she's done her MCH, surgical oncology, Tata Memorial Hospital, Mumbai. And she's a consultant surgical oncologist, Thangam Cancer Center, Namakkal. And her special interests are robotic laparoscopic pelvic surgery, complex surgical oncology, peritoneal surface malignancies, and breast cancer. Welcome, ma'am.
Thank you, ma'am. Can my presentation be opened there or should I?
Yes, ma'am, you have to.
Saiti is open, na?
Almost downloading.
Almost. Okay. Yeah, I can now open. Should I open, ma'am?
Whatever is comfortable, Deepthi.
Or ma'am, Park. Just I'll try to. I'm doing it. It may take time. Here also it is taking time.
No, I think Sahiti has already opened.
Okay, ma'am. Then we'll go by that. Wait.
Sahiti, you have opened, no?
Because the file is huge, ma'am.
No,
The video is there.
Deepthi ma'am's screen only, but I'll just share, ma'am. Just know it got downloaded.
Okay.
Yeah. Before that, thank you, ma'am, for including me here again, especially Sampath Kumari madam, who remembered me to keep it here. I was listening very interesting discussion on the benign breast disease. So madam has given, if I am allowed, you told that nobody else can ask and answer. That's why I was keeping mum. If you allow me, till my presentation is opening. So yeah, it got open. So I should not talk. Yeah, ma'am. Sir, ma'am, can I control it or you will control there?
No. See, since I told they are young, no, I thought let the judges ask. Other than that,
No, ma'am. This presentation, can I control or they will control, ma'am?
You can. Deepthi, whatever is comfortable, you do it, Deepthi. If you want to control, she will do.
Yeah, I'll once give it to you, ma'am. Once please check. I'll giving the access. Once please check, ma'am. If it is working, we will go ahead.
Yeah. Thank you.
Yeah, once please check by changing the slide, ma'am.
No, I'm not able to change, I think. Not able to change, ma'am.
Okay.
No, now I'll see, wait. Yeah, you have to do, I think so.
Ma'am, one more thing, ma'am. There will be 2-second delay, ma'am, since the network is on.
Fine.
So first changing the slide, please kindly note that. Yeah.
Yes.
Shall I go to the next slide?
Yeah, I'm ready.
Yes, ma'am.
Yeah, so thank you. Already many things have been discussed about the last speaker. Beautifully, she has covered all the things. Just because the topic, madam, has given me the updates. So we know that the breast cancer is one of the malignancies that day by day the treatment is, the new things are coming, not only in the treatment, but in the diagnostic also. So last, we were discussing about the digital mammogram and all, I think so. Next, please. The time has moved for long to the tomo mammogram. I think so. The last speaker will agree with me. Be here. So the thing is, many times, which it's not the tool, especially these all the things which have been when we are going for a diagnostic for a dense breast. So you can see on the left side of that image, there is nothing. It is a dense breast only showing. When you do it tomosynthesis, the reconstruction, it is just like a CT type of technology. When you do it along with that, you can see a suspicious lesion is there. And in last slide also, the same thing has been shown. So the tomosynthesis has come. MRI was there for long, so I'm not mentioning here. Many centers are now adapting with this. More than that is AI assistance. So AI assistance is coming for many many cancers. And in our hospital, even we have launched for the lung cancer recently. This is a research in along with the VIT we are doing, because many a times AI help us to diagnose whether we can avoid unnecessary biopsies, unnecessary FNACs, and it give us the more and more the data is accumulating, the accuracy of AI assisted imaging is increasing. Next, please. So that these are the new things which are coming in the diagnosis. So already, doctor, you can play this video, ma'am. So last time, I think so also in a presentation, I have shown this video. Why I'm insisting it again? So gone are the days when we were treating these patients with the FNAC. Why? Because if the now currently the evidence is saying even in a more than 1.5 or 1 centimeter tumor, until we know what is the immunohistochemistry status, what is the receptor status of a patient, we should not treat. Why? How will it change? Because a patient, suppose we do 4 testing. We do ER status, PR, progesterone receptor, HER2 new, and Ki67. So how it adds? When we do in FNAC, we cannot do IHC. For a very small tumor, yeah, we can do. Here we do all the IHCs, and if it is tumor is triple negative or it is HER2 positive, so it is nowadays evidence that these patients should receive chemotherapy or targeted therapy, even if the tumor is very small, even if it is less than 2 centimeters. So core biopsy should be done. Next, please. Core biopsy should be done for all the tumors which are more than 1 or 1.5 centimeter. So now coming to the surgical advances. So the reconstruction we know are there. There are many types of flaps. There are many types of things which have come, which can earlier we used to do only latissimus dorsi, but the everyday plastic. Next, please. Now, plastic surgery is improving. You can see here the simple technique of oncoplasty can give a very good shape, and definitely this is the time that every lady should be offered for the breast conservation or reconstruction. If you deep dive while the counseling, you will see still in India, the decision is being taken by the by the husband or the family members. The ladies are not being allowed, but the time is changing and every lady has right to undergo this type of conservative. Next, please. And the reconstructive surgery. So this, I think so, this is a very interesting case. I don't remember whether I have shown it last time. This lady, she is very young lady. She's only 36. She has a suspicious lesion, which was not palpable. Rather, she had a vague pain, and on ultrasound, we had a suspicion. So we did FNAC, it came out to be positive, and then we did core biopsy. So she was for a hormone positive lady. What you can see here, large ptotic breast hanging down. So these type of tumors with these type of ladies, what happens when we operate directly? Please, next, please. So what we do in this type of cases, we have to take the care of the size of the breast also, not only for the cosmetic purpose. When these ladies, they go for the radiation therapy, if it is a large, huge ptotic breast hanging down, it hampers the radiation and it causes lot of side effects. So this lady underwent sentinel lymph node biopsy, wide excision, and bilateral reduction mammoplasty. So we have to think about in that line also. Next, please. So reduction mammoplasty is a procedure which are actually now, next please, ma'am. The reduction mammoplasty is ladies simply coming for cosmetic purpose also for this, but malignancy, we have to remember that it has to be done for the treatment purpose. You can see now she was actually very happy after post procedure. Next, please. So when I have written here about the sentinel lymph node biopsy, I'll just want to take few minutes of yours. The sentinel lymph node biopsy, all of us know it as the first draining node, and all the treatment for the cancers are now moving for the de-escalation. Especially in the breast cancer, we have gone from radical to lesser one, and now actually in the axilla also we are going for the de-escalation. So what happens here? If a lady, even if she is having a big node, while taking what we do before starting a chemotherapy or any neoadjuvant chemotherapy, we have to tag the node. It can be put by a clip. Yes, it is costly. Sometimes they put carbon particle. There are many things nowadays coming. So people, the surgeons, they tag it while taking an FNAC. We have to prove it. Okay, the node is having the disease or not. Tag it, give chemotherapy, and post chemotherapy, if she's having good response, even these patients can undergo conservation surgery. There is Nothing like there is a contraindication in advanced, locally advanced breast cancer also undergo breast conservation. But it is important to target these lymph nodes beforehand. So it is known as TAD, targeted axillary dissection. This is new, which everybody is moving on. Next, please. So now the comes, that the Angelina effect, nowadays people are going for the all genetic, the hereditary breast cancer, for the prophylactically. Sometimes we require not only prophylaxis for a small tumor, but there is a diffuse DCI, the ductal carcinoma in situ, where we cannot leave the parenchyma behind, but the tumor is too small. So there are skin sparing mastectomy. There for long it is there. Now the word is moving to next, please, ma'am. Moving towards this is a robotic video, not for the breast cancer. I'm just showing you which the robotic surgery is coming in all the field, and the breast cancer is not untouched by the field. So where and how it is useful. Next, please. So this is the robotic where I'm sitting on the console and operating, but this is a particular breast cancer surgery is being performed. Next, ma'am. This was a robot just to show in the what you can see from this small plate, ma'am. Yeah, so there will be some background noise here. So what is the small incision is being taken in the, you can see the anterior axillary line. Some fat tissue, we have to lift it up. Then we have to identify the pectoralis major. We can just, there are some lighted initial just to put a port. If you have seen, there are for operating anal canal or all, we use gel port. So same port what we do, we use in this also. So the dissection is being done. The muscle, the breast tissue is completely taken up from the pectoralis major, and then the axilla is being dissected from here. Full surgery can be done, and actually why it is useful when you are doing a skin sparing mastectomy. Otherwise, it was really a tiresome. Mastectomy is actually, it takes around 1 hour for any oncosurgeon to do, but these skin sparing mastectomy used to take definitely for 2 or 3 hours. So this is with the invent of this robotic, rather inclusion of these robotic skin sparing mastectomy, it is picking up very fast way, and many centers who are doing robotic surgery are adopting, and the breast cancer surgery as a preventive surgery and skin sparing surgeries are being done in robotic way. Next, ma'am. Next. So now again, so here actually I am just keeping myself only on the updates. I'm not talking much on the treatment. So another thing in surgical thing, this actually we do in our center. So what you can see, around 15 to 18% of ladies, whatever kind of surgery you have done, whether you have done sentinel lymph node biopsy or you have done axillary dissection, lymphedema is a cumbersome problem, and it can be very worrisome in day-to-day life. The ladies, they suffer a lot. Rarely we have seen, recently some patient was referred for lymphedema, and there was a lesion which came as even sarcoma. So they can lead to angiosarcoma also. So lymphedema, there are 2-3 things, new things have come. There is something known as lymphoma, and there is lymphovascular anastomosis. There are 2 ways. It can be that you can see under microscope. So these are coming under super microvascular surgeries. So the same thing what we do, ICG is a dye which is being used for the sentinel lymph node biopsy also. Same dye is injected in the web space of a lady before surgery, and we identify this. You can see the lymphatic. Lymphatic is being identified. The transparent one here is the lymphatic, and it is being joined with the vessel. So on table we create a lymphovenous anastomosis. So it ensures that the circulation of lymph is well maintained, and yes, it needs expertise. Sometimes there are failures. Sometimes the multiple anastomosis need to be done. But if a patient comes later on, suppose we cannot do it on table and the patients come in the post-op, then what it can be done? It can be done under local anesthesia. Yeah, it takes time to anastomose, but the anesthesia requirement is less. So we have done for few patients 3 or 4 anastomosis under local anesthesia. So most of the centers who are performing high volume surgeries and now offering these patients about the on table or post-op lymphovenous anastomosis. So this is now important to know about the breast cancer surgeries. Now the advances in the radiation therapy, it's not new. Yes, but the many centers have not adopted yet. So the tumors which are the interstitial brachytherapy which we can offer these patients is so that the patient has around 3 centimeter tumor. So the criteria is this should be hormone positive, note should be negative. The tumor should not have any high risk factors. So what you can see, we have just put some brachytherapy wires. So when the final histopathology, first we send it for the frozen section. We do lymph node dissection, send it for frozen, but we do not start the treatment. We request our pathologist to give the report fast. And if it is sitting in the criteria of this good category, then we can take the patient for the interstitial brachytherapy for 7 to 10 days of treatment and done. Patient doesn't need not to go for the full external beam radiation therapy. And suppose the patient comes positive and she's not fitting up for this criteria, these wires can be used for the boost as well. So interstitial brachytherapy can be included in a well-selected group of patients. Next, ma'am. So advances in systemic therapy, there is a huge lot, I think. So this time will be insufficient. And just one thing I'll show here. This was a lady. You can see on the left side of the PET CT scan, the liver was studded with the mets, all black things, wherever you are seeing, except near the bladder, is the metastatic disease. She came with a positive, she was HER2 positive. So currently we give trastuzumab, pertuzumab. These are anti-HER2 therapy. You can see after the second targeted therapy, she had a beautiful response. And this is actually, if we say it is type of magic which is happening with these type of targeted therapy. And you'll not believe earlier these patients. Yes. One more thing I want to add. This lady particularly benefited by the trial because the company had which we are part of this study. It was a biosimilar study and they provided the molecule free of cost. Actually, it is very costly. But yes, it is available and people are offering in this trial setting. We can offer these patients and it is a beautiful drug for this kind of HER2 positive patients. So now the scenario is changing. Next, please. Again, if there are many, every day something new is happening, but few things just I have kept here because I think so. This is if you invite some medical oncologists, they will take 20 or 30 slides to only talk about these therapies because every day one new molecule is adding, which is difficult to remember for a surgeon. So this is I want to add here hormone positive metastatic breast cancer. Now we don't go for the chemotherapy. There is a drug which is CDK4/6 inhibitor by the name of ribociclib or palbociclib. So now we start the treatment with these molecules, not with the chemotherapy. There are certain drug conjugate in which they have added targeted therapy along with chemotherapy. So these drugs are actually sometimes first line, second line treatment for the metastatic disease. Maintenance therapy, what has happened, because we know about the triple negative breast cancer, we have nothing to give them post-operatively. That's why, back ma'am, back. So still we don't have any target for these triple negative, and these are the patients who perform the worst if we see them in the prognosis wise. So the thing is, for the maintenance therapy, why I was mentioning earlier that these patients should receive, we have to do core biopsy, see if they are triple negative, and after giving chemotherapy, if they have a residual disease. So nowadays we have to give 1 year of capecitabine, which is the oral molecule for the 5-fluorouracil chemotherapy, and it has shown the benefit. So these are the things currently being followed. Next, please. So again, I was talking about the de-escalation. So it is very difficult to counsel somebody for the chemotherapy, whatever is the social strata, wherever they are. It is really the most difficult task is to counsel somebody for the chemotherapy. So there is a selective group of patients who can be safely taken up for only hormone positive, and we have patients who are surviving for more than, I think so. The can assist, this test I'm showing was not available, but there are certain other criteria which we can do, and they are surviving well on hormone positive. So those 2 tests I have seen, these are genetic profiling tests in which the tissue they analyze that what is the type of, what is the risk category of these patients, and after risk stratification, low risk patient we can safely keep them on hormone therapy. Oncotype DX is very costly, around somewhere around 2 to 2.5 lakhs. This can assist is Indian answer to the Oncotype DX. It costs around 60 to 70,000 patients, and you'll not believe many patients are opting for this. And if the risk is low, we are keeping them on the hormone therapy. Next, ma'am. So I've just picked up few things solely. If you ask me, the maximum work is being done in the medical oncology. The surgery is going lower and lower side. The maximum thing is happening in the diagnostics and in the medical oncology. Because people are joking on us that one day you will be obsolete. So I tell them that I will be still alive to put chemo ports, because these patients may require some kind of intervention for that. So the maximum work is happening all these. So I think so the breast and the lung cancer are the two cancer with day by day new things will come. And these are the which I saw, and these are the new things which all of us should know as a clinician. So I would like to thank again to whole panel and all senior gynecologists here, and to just giving me some time to present all this. Thanks a lot, ma'am. I think so. This is the last slide. Yeah, I know. Just okay. Thank you, ma'am. Yeah, thank you.
1 minute, Dharani, you post Sagiti, you post the last slide, the photo. Yes,
Yeah,
this is Dr. Deepthi.
Yeah, ma'am. I am.
She is in Kanpur.
Yeah, ma'am. Yeah, I'm sitting in IIT Kanpur actually.
That is the reason I am showing everyone that this is Dr. Deepthi.
Yeah, ma'am.
Okay, thank you, Deepthi. Wonderful talk. No
Thank
chat.
you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Yes, now
So
yeah.
the-
Radhika,
yes.
what up? Thanks.
Yes,
Any
ma'am.
doubt?
Ma'am, there is some questions in the chat box, ma'am.
Yes, Dr. Dharani, you can use this armiloxifene in mastalgia, definitely. Ramani madam is flying to Kannur, so she may not be answering. That firm fibroadenoma, no idea. Armiloxifene only for, usually we give one dose for 6 months and 1 dose for 1 month. I think that is the way we can give. Other than
Ma'am,
that.
can I intervene here? Can I answer here, ma'am? If you allow.
Yes, Deepthi.
Yeah, ma'am. So I'll tell you the armiloxifene is a very good drug. Please, 2-3 things. Actually, I'm really happy that you people are so informed. I always feel so good in this group. That is armiloxifene you can use in 2 categories. A lady presenting with a mastalgia and with fibrocystic disease. So the best way is to give is alternate day. Give it alternate day. And 2 things only they need an explanation, because your gynecologist must be knowing the oligomenorrhea happen and very few patients have allergic reaction. After 6 months, you can. So earlier was some different dosing. Now we do just 1 alternate days for 6 months. Is a very good drug for the mastalgia and the fibrocystic. For fibroadenoma,
30 milligram.
30 milligram, ma'am, low dose.
Okay.
And fibroadenoma, still not convinced. We do not give. Rather, you keep them on observation. Still not very happy with the kind of response with the drug. Thank you, ma'am. Sorry for the.
No problem.
Yeah.
Thanks for the information. Okay. Yes,
Yes, ma'am.
Dr. Radhika, if there is no questions, you can proceed with vote of thanks by Krishna Papa.
Okay, ma'am. Thank you so much, all the delegates and the faculty for the lovely CME. Thank you, Sampath ma'am and Vidya ma'am, for the opportunity. I thank Parag sir, Durga Das sir, and Chandra ma'am, Ramani ma'am, Dr. Shanti ma'am, and Kartika ma'am for giving their valuable time and acting as judges. Thank you, dear speakers, Dr. Dharani and Dr. Jayamina, Dr. Deepthi ma'am, who, amidst the short notice, you were able to do a very good presentation and very informative. Thank you, Dr. Deepthi ma'am. And I thank Sahiti and Mrs. Sri Priya for the IT support. Thank you, ma'am. We'll meet on the next webinar. Thank you, Sampath ma'am.
Thank you, Radhika.
Thanks a lot, ma'am.